Welcome to another edition of our Focus on Facebook Live. My name is Husnain Kermalli. I'm the Chief Medical Officer here at St. Mary's Hospital in Attebery, Connecticut. Each month we like to highlight a special clinical area and explore the different clinical expertise that we're able to bring to the community here in Attebery, as well as our patients here at St. Mary's Hospital. And I'm really excited to bring together today, especially this month, Trinity Health in New England breast surgeon, Dr. Lisa Attebery.
Thank you.
Thank you very much for coming, taking time out of your busy day to be with us today. We're going to talk a little bit about advances in breast cancer treatment in a few minutes, but let's learn about you for the first couple. New here to the Attebery market and joining our group here in Attebery just over the summer. Excited to have you on board joining our team.
Thank you. Yes, joined Dr. Sealing, Dr. Sukan. So came from Rehoboth Beach, Delaware, where I had my own practice.
Yeah.
Breast surgical oncologist, fellowship trained, oncoplastic reconstruction, boarded in general surgery. So I bring a different skill set to the group.
Yeah.
I'm happy to be there and build this program.
We are excited because now we've got 3 board-certified breast surgeons here at St. Mary's Hospital in the Attebery community.
We have the largest number in the entire state, actually.
In the entire state.
Right. Yale has a bit of a turnaround. Hartford has some. They're having a little bit of a turnaround, but probably the most experienced group you have in Connecticut.
Right here.
Dr. Sealing, Dr. Sukan, and myself. Yes.
Love to hear that. Love to see what we're able to give to the Attebery community.
Absolutely.
And I think beyond that as well.
We are. We Dr. Sukan brings a group, Dr. Sealing brings a group, and then for me, I bring a lot about a state. So we really are going to bring a lot to the community.
Absolutely.
Right here.
But let's talk about how your journey into medicine developed. Understand your mom was a pediatric nurse.
Yes.
And you'd occasionally accompany her into some of what she was doing. So tell us a little bit more about that.
Yes. So my mom was a pediatric nurse.
Yeah.
Her pediatrician, Bob Sylvester, was a great guy.
Okay.
So he would let us go into his office, which, having like a 5-year-old in the office is never a fun thing. So I just really early on really liked medicine. And my father was a businessman, and so I think I was probably 9 years old, maybe 10. And my dad said, "What are you going to do when you grow up?" I'm like 10, right? And I said, "Well," and I do art as well. I'm an artist. And I said, "Well, I really like art. I think I'm going to do art." My dad said, "You'll starve." So I said, okay, well, my next love is medicine. And so at that point, it was that's the way it was going to be. Through college, and then went to med school. I actually thought I was going to do orthopedics because went to college on a full ride basketball scholarship.
Gotcha. Wow.
But then I did my first rotation, and they disarticulated a hip, and I about wanted to vomit when that popped out. So that made me switch, and then I got into surgery, and then happened to have a really great mentor, Dr. Mary Martucci, who was a breast surgeon, general surgeon. Really latched onto that, like that component of it, that care of like from beginning and lifetime, and then did some extra training for plastics and reconstruction, knowing that there's a need. There's only about 10 to 15% of breast surgeons fellowship trained in the country that actually can do their own reconstruction. It's expanding now. It's just at a conference now where those numbers are going up. So did extra training where that need is, and so this is where it comes.
So what is it about breasts, the field, that motivates you to continue the expertise that you're developing there?
So that's a really great question. So you and I both know in medicine you kind of get stuck in those components. If you're an ER doc, it may be congestive heart failure, it may be that whatever, heart attack. For oncology, it changes so rapidly.
Okay.
And so the nice part about a breast surgeon is whenever you have a med student, they think, oh, it's surgery, you're in and out. It's not that. You meet this patient, there's an abnormal mammogram, you make the diagnosis, then you meet the entire family, right?
Yeah.
We're that point person for them forever. They get very, very attached. Yeah, you know them forever. And so you kind of navigate them through that system. And not only do you build this relationship, you get to know like the second generation as that goes forward. And then you have the challenges of how quickly oncology is changing, right? So not only is it satisfaction where you get these long-term relationships, like I'm fortunate to have patients that come from out of state to still see me, but have that challenge of it changes on a daily basis, molecular therapy, immunotherapy that we're doing now. So it's intellectually very challenging. The surgery is changing as well, but the patients are really kind of your core.
And it's remarkable just how quickly things are changing. Was doing a project with my daughter, and we were talking about proto-oncogenes and tumor suppressor genes, and And I'm a molecular scientist as well, so I was like, oh, this is fantastic. But
That's good.
we were looking at, you know, some of the new discoveries that are coming out, and they are completely turning things on their head.
They are. People are, you know, people live with diabetes, hypertension. Now people are living with metastatic breast cancer.
Yeah.
You know, we have a lot of advances. I think breast is so high profile. You know, lung cancer is the #1
Sure.
cancer, but breast is very high profile. A lot of money going into research.
Yeah.
And now these immunotherapies, you know, the Keytruda,
Sure.
that's coming into breast, for all of those. So the whole field of like chemotherapy is definitely going away as we see it. So your daughter's like, they're ahead of it, right? To even hear that, how old is she?
She's 15.
Yeah, that's
Yeah.
crazy. She's 15 and being taught that,
15.
right? But it's just evolving so fast that,
Yeah.
you know, I have a patient, she's 49, she's been my patient for 3 years. We diagnosed her and had metastatic disease to her bones. She's on one of the pills, I think she's on Ibrance, no disease. And that's how she's going to go for a long time unless something pops up, and then there's going to be that next generation.
Right.
So getting down to that molecular level is just amazing. And I think we're just about 10% of where we're going to be.
Well, and we keep learning the interactions and the extracellular environment,
Yep.
some of the work that's being done, and so it's an exciting time in that field for sure.
It's a good time, not that you ever want to have cancer, but you know, some of these that we're just like really dealing with, it's and managing it versus that death sentence when somebody walks in and they say, oh my God, if I have breast cancer, I'm going to die. I'm like, well, really, not really. I mean, I've been in practice for 17 years and I probably have about 20 deaths. That's not a lot if you think about me doing 700 cases a year. So it's changed so much. The people are living with it. People are walking around the street now with disease and they're just managing it.
And they're managing it. So you're also bringing new technology. You brought new technology to the Waterbury area, and something called MagTrace. Talk about that.
So the history of, you know, when we were residents, right? If you had a non-palpable breast cancer, you know, they would go to radiology or else we'd biopsy it, but you can't feel it.
Right.
And so if it was an invasive cancer, we would want to test the lymph nodes, the sentinel nodes, which are the gatekeepers that drain the area. It was always a radionucleotide and then blue dye. And then for the breast, they would put a guide wire into that breast, which imagine going from radiology, you're traumatized, you have breast cancer. And then you're traveling down the hallway, you're getting a guide wire in your breast, never comfortable.
Right.
And then you're going down to get a radionuclide injection, which doesn't feel good. And it's a radionucleotide. Who knows what's going to come out in 30 years from that.
Sure.
And then 4 hours later, they're coming to the OR. So in about 2018, Ethicon came out with basically MagTracer and MagSeed. So MagSeed is a tiny granule, just a magnetic. That's all it is, particle.
Right.
So instead of putting a guide wire in there, you can just, when you do the biopsy, you can drop a MagSeed. That emits a signal for almost 9 months.
Okay.
And so why that's important, if you have somebody that comes in, they have positive lymph nodes, you think you're going to get treatment up front, you can still identify where that tumor was.
Right.
So not only that, and then the MagTracer is a liquid magnet. And so instead of going to radiology, there's no needle look, there's no wire going into the breast.
Okay.
Preoperative area or in your office, you numb up, you put in the MagTracer, liquid magnet. That's it. Patient goes to sleep. So you get rid of all that trauma on top of it, go to sleep, identify, I have a probe that I can identify in the lymph nodes, exactly which lymph nodes to take out,
Right.
which is accurate. You want to be less than 4 for
Yep.
lymphedema rate to be 1 to 2%. Very targeted, and not only that is you can put the probe on the breast, identify exactly where the mag seed is, and take it out, and you're done and over with it. And so it allows people to be, they could be in the middle of Oklahoma with nobody around, but they can still have their surgery. And so patients now, they don't even have an idea about the needle look. Like, that's so antiquated. And I really do think it's like the most advanced thing they've done since the 1980s when partial breast came out.
Yeah.
So we were able to bring that technology here. You know, they're getting used to it. The surgery center loves it. Patients have no idea about, you know, what they're missing, except when you have another patient and you re-diagnose them, and the first thing they say is like, do I have to get a wire in my breast? I'm like, no, you don't.
Wow.
So it's a whole different world out there of knowing. And then, yeah, it's a great technology.
Well, I mean, and we've talked about this a number of times, that our focus has to be on the patient's experience.
Yes.
It can't simply be we're going to be doing things the old way, that they're going to sit there and experience the same discomfort that has been present in medicine. Medicine doesn't have to be bitter anymore. And we
That's
need to
right.
focus in on, as the providers of that, the tools that are able, it's not simply about getting the information that we need. It's getting the information that we need in a way that's acceptable to the patients.
You're right.
And we're moving very quickly to that, where that patient experience is at the highest level of the care at the first thing we have to look at when it's about the care that we're delivering.
You're right. My kind of biggest pet peeve is I hear some go, well, we've always done it like that way. I'm like, well, this is 2023 and times have changed. And if you're not changing, then you probably shouldn't be working in that, because it's patient driven. And, you know, you hear patients where they had a horrible experience. I'll do a biopsy on someone and they've been traumatized.
Sure.
And I'm like, no, it's going to be very, very different. So it is changing that perception of how medicine, it's not, you know, antiquated, it's not torturous, there shouldn't be pain. And I mean, there's always some pain, obviously, but it should not be torture. Right. For sure, absolutely.
So love to hear we've brought that on board. I think all of our team is moving towards that technology.
That's the goal, yes.
And so let's talk about, so that's technology A. What other new technologies are we bringing on board here? And
Technology B.
Technology B. What's technology B?
So up until like 2016, if you had mastectomy, so nipple-sparing mastectomy has really been the standard of care for a long time now. But to do reconstruction, up until 2015, we would have to, you know, you do the mastectomies and you're kind of left with this skin envelope, right? And we would put tissue expanders, which are basically like flat balloons behind the muscle, the chest muscle. So as you imagine, as you try to expand that pocket up, no patients like you, because you're taking the muscle and you're kind of ripping it off the chest, really what we're doing. But it creates that pocket in there, and then at a later date we would take them back, you know, if they went through chemo or whatever it may be, and then put another implant in. So you really, patients at minimum had 2-stage procedure, probably even 3-stage at that point. So in 2017, everything got flipped. So to doing direct implants, 1-stage procedure. So instead of having that tissue expander behind the muscle, can take an implant with a special mesh that's basically cadaver mesh. The military used it. You can drop it in you can drop it in soil and it won't get infected. You can pocket that around the implant, put it in. It's a 1-stage procedure.
Wow.
That's great for the patients. The bad thing for the surgeon is the complication rate's like 54% because they have no pain. Right. Which goes back to our problem. We don't want you to have pain, but this is an instance I do want you to have pain. Sure. But up until here, and I know Connecticut has this no drive-by mastectomy law, but everywhere else, I would do it at a surgery center and send patients home. They really don't have pain at all. They get immediate, I mean, they get to the healing process, but if you can lock them down for 8 weeks, 1-stage procedure, and they just do great with it. And so, once again, less trauma. You know, they walk out of the hospital, like, their reconstruction is complete. Hopefully it stays that way. Yeah. And, like, nothing happened. It just moves right on with their life. Sure. Which is a great technology to be able to do. So, yeah, the 1-stage procedure is where we should all be. I think, you know, there are areas of the country where they just don't have the technology, the personnel, the experience to do it. Sure. But yeah, that's a big thing. That's a huge advance. I mean, to walk out in 1-stage procedure and have drains, like, patients are just ecstatic.
And so this is, again, picking the right patient for the right procedure, but making sure, again, we're focusing in on their experience as it goes through. Yes. Not doing things just the same way just because. That's right. But trying to understand, is there a different way, is there a better way that allows for an effective treatment, because we still want to be effective. Yes. But improve their experience as they're going through it.
Absolutely. It's all about listening to the patient and trying to not have a fear factor for surgeons. A lot of surgeons have fear factors. Oh, I can't change my ways, because you and I have both seen like, I've done it this way 100 times and I'm going to continue. You have to be able to adapt, right? And patients are savvy now. You know that. They're on the internet. They're looking. They research. They all that. So it's, giving them the best experience, but also giving them the highest level of care. Right. Where, we want to be standard of care, but yes, it all goes together. And you can do it quite easily. You just have to be invested in it. Right. And you have to be willing to, step out of your comfort zone to do it. So that's the challenging part about surgeons. We're all unique personalities. Yes. We're all challenging personalities, but getting out of that comfort zone.
Now, when we talk about, and you had alluded to this as well, the patient and the breast surgeon, their relationship is very, very close. And I'm sure you get pictures of their children and their grandchildren, and they send you Christmas cards. You almost become like their primary care doctor to some degree. So how do you collaborate from at least from the breast oncology world, let's say? How do you collaborate, or what other collaborations with the other providers do you help with along the way?
Great question. So your surgeon, we're usually the point of entry, right? It's rare to have a diagnosis. I mean, you'll get second opinions, I'll get second opinions that come in, but you're usually making that diagnosis or facilitating that diagnosis. Sure. So once you get them in there, you have that immediate connection. You have that hour consultation, and then you bring in your colleagues. Here we have our multidisciplinary board, so you have medical oncologists on a Friday, radiation oncologists, or genetics, social workers, everybody there to bring everybody into that team. So it really is a big team approach. The challenging part, I think, for those other people are those patients are attached to us, right? We've given them a diagnosis, we've given them that safety net, and so you have to instill with the patient, no, I trust this provider, because we all want to take care of you.
Right.
But it is a very unique connection, but it is a whole team. There's no way. I mean, you need all those components.
Yeah.
From the person that answers the phone to the person that, like a nurse navigator, those are the key people. So we're all very important in it. But we just happen to be that touchstone, and they are really attached. I have patients that come from, still follow me all over the country. It's just a attachment. And they do ask, can you be at my primary? I'm like, no. I cannot manage your blood pressure very well. It will not go well, but yes, absolutely.
And I love to hear, again, this multidisciplinary team, that the patients may not see the team coming together around them, but they have to know that there's an entire team that's surrounding them and supporting them as they go through this very, very difficult journey, that they are not alone as they go through this diagnosis and the management of it.
Yeah, it is a whole team approach. I mean, every aspect, there's a lot of communication behind the scenes that patients don't realize.
Yeah.
There were some models where they would bring patients in on the diagnosis, and they would go from the surgeon to the medical oncologist to radiation. Imagine in one day you're getting overloaded with all that information. That was just, to me, a very bad model. And so patients, when we talk with them, there's a lot of communication that, when a patient goes in to see Dr. Madrano, one of the medical oncologists, they'll, okay, we've already talked about it, they already know. So all this, I said, it's behind the scenes. I said, but everybody's going to know about you. Everybody's going to know the plan. I said, I'm going to know your plan. I said, usually your surgeon's your quarterback, but everybody's involved in your plan. It's not just a focal. So that's the way it should be. And that's what we want. We want everybody to rally around that patient, not just one.
So, big month, October.
Yes.
Breast Cancer Awareness Month. A lot of pink being worn.
Yes.
Not today, unfortunately, but it's out there.
It's fall.
It's fall. It is fall. It is fall. And a big push for screenings. So let's talk about breast cancer screening.
Hot topic.
Big topic.
Yes, and so the American Cancer Society just kind of came out with their recommendations, which are a little bit off. And so, we'll get out of just the regular population, not high risk. So baseline at 40 every year until 50, and then they said every other year after that, which is a problem because women are most commonly diagnosed at the age of 62.
Okay.
In the mid 15, the government did a research and came out with every other year, we saw a huge uptake in young people missing their mammograms.
Okay.
So the American Society of Breast Surgeons is where we all kind of sit as breast surgical oncologists. So it's yearly at the age of 40 until one's life expectancy is less than 10 years.
Okay.
So we don't miss that. Women 62, men are diagnosed at 71. So that's kind of where we sit with that. When you get into high risk, that's different. Are they high risk because of the genetic mutation?
Sure.
The genetic mutation, now we're going for 25-year-olds to start MRIs. That's a lot of radiation exposure. So it's trying to figure out where they fit. And then you have another population that's just high risk based on models. The Gale risk model, the Tyree-Kuzak model, MRI, mammograms. So those are a little bit ebb and flow. But the standard when somebody comes to me, if they're not high risk, is 40 yearly thereafter, unless, something is going on with their life expectancy. And that becomes challenging. I just saw an 87-year-old. She's probably going to live another 15 years. And so, she had 2 breast cancers, so am I going to stop screening on her? Probably not. Because of her, her own, even though life expectancies, she's probably going to live that long. So I might have a 50-year-old that's not healthy.
Sure.
So it's balancing that out. But 40 every year until that. Kind of sit with medical. Yeah.
So mammogram. Is that the screening tool of choice?
So it's.
I'm gonna ask still.
Yes.
Only because we're talking about technology.
Yes.
And mammogram to me has been around
for a long time.
For a while. Is it still the technology of choice? Because everybody's like, well, can't you do a scan?
Right, the magical scan.
The magical scan.
The magical cancer scan.
The magical can, the wand.
Yes.
Yes.
So, the original was 2D mammogram, right? 2 views, on top and to the side. And then, 3D really came into vogue. So 3D does really 80 slices of the breast. Very, very good. They work at different components. A regular mammogram will look calcifications, some asymmetries. The 3D will really catch those dense breast tissue. So you ask about technology. So that's kind of your standard. Here in the state of Connecticut, which no one else in the country does, there's a screening ultrasound that we really don't recommend. It really should be a targeted ultrasound. Screening is really predicated on your tech. They move the hand. So your ultrasound should be something targeted. So if you have a normal mammogram, then you can target it like left breast, 12 o'clock position, 3 centimeters. If that's even inconclusive, then your next step is your MRI.
Okay.
So MRI works really different.
Sure.
It is based on the physiology, meaning the blood uptake of the breast. So you have type 1 kinetics, flat, nothing's going on. Type 2 can be hormonal. Type 3 is where there's rapid blood flow. That will target down to millimeters, and that's a very sensitive test. It's not a screening test. So I think when you put all of those in there, those are, you can get to where you need to be right at this moment in time.
Right.
3D is for sure. Radiologists are now doing, of course, AI, right? They have iCAD, so they've had computer-aided diagnosis, which helps them with calcifications. iCAD now scans all the images and looks at areas of densities. So if they scan that across a mammogram, they'll see an uptake in the density and think, okay, something is there. That will target more. So the mammogram is kind of the standard. Ultrasound is not screening, but they supplement each other with it as well. There's something they did, I forget what there was a heat scan that they did, a thermography, not indicated. Right, it's a cash business, so it's always a challenge with it. But all those are very effective with it, and also just being engaged by a patient, right? But yeah, the mammogram is not what you think anymore. It's, like I said, it's 3D, there's 80 images each way, there's reformatting it in the MRI, so yeah.
So it's a much more sophisticated method of looking at the breast.
Yeah.
It's quick, it's effective.
Yes.
And
it's really painless. The 3D is less pain than the 2D.
Okay.
Which is good. Some patients are thinking, oh my gosh, it's painful. I'm like, it's not really. The 3D is very quick. Radiation is a little bit higher, but probably less than we're all getting on our cell phones and microwaves every day as we walk by them.
Right. And it really works well as a screening tool.
It does.
Because what we don't want is to have false positives.
We
do. If we screen very, very high, we're going to start to do more invasive stuff.
That's right.
Which is not what we kind of want to do.
That's the challenge.
Yeah.
Right now is, in the breast cancer world, we diagnose things that are 2-3 millimeters. And now it's pulling back because we've overtreated.
Right.
We've gotten so good at doing that. And then the radiologists probably recommend more biopsies than they should, but they're, afraid of missing, right? So it's that societal push. And then if you miss, then you've maybe the attorneys. So it's balancing that out with it, absolutely, of trying to limit it. And that's why breast surgical oncologists are really important for patients to come in. We harp on the films because we as surgeons don't trust anybody. That's our mantra.
You have to look at the films yourself.
That's exactly right.
Yes.
If you didn't see it, it didn't happen.
If you didn't see it, it didn't happen.
So those are really important.
But that's
things.
the collaboration. I think we do it in medicine too, right?
Yeah.
We want to see what the chest X-ray shows.
Absolutely.
Even though you have your report. So I don't think it's just surgeons.
Yeah.
I'll take we good that in medicine.
Because we get the hit for not trusting anybody. I'm like, well, it's a big deal, right? If someone patient is giving you their life, what a bigger honor could you have?
Right.
And so it is. It's just, what we have now is really, really good. There's also that check and balance. Radiologists, I may call the radiologist. We may go back and forth with things. That collaboration with them is what's important.
So, all great things. I think Breast Cancer Awareness Month, we're raising a lot of funds for the research along the way. I think we've got a Pink Out event happening October 26th. So we're excited about that from the city of Waterbury. We're all going to be dressed in pink and out there and encourage, I think, everybody just to gain awareness. I know even football, you see them with those.
I know
the multicolored hats,
the shoes,
the
pink
too,
shoes,
the pink shoes.
It's all good.
All about breast cancer this month.
It is. It's there's a lot of activities going on, and it's interesting. We do all this awareness. But you still have people and we'll talk about take homes of there's still that, I'm not going to get it done, I don't want to know, kind of that situation. But we have a long way to go. But the nice part about that, it's high profile, so it's generated a ton of funds and a ton of research. Yeah. You hope it starts to trickle down to other disease processes, that aren't doing so well, right? There's the pancreatic, those melanoma, not as high numbers. We'll see that you'd like to see, but yes, we are very fortunate.
And so let's talk about that take home message, that pearl for our patients that you want to let them know so that we can continue moving the journey forward.
So the biggest thing is whenever I give a lecture, you get the whole crowd. You'll have somebody who'll raise their hand and go, my mom had breast cancer, I'm going to get breast cancer. And my take home is 60 to 80% of breast cancers have no family origin. None. We don't know about 60 to 80% of them. So when people think, oh, I don't have a family history, I'm more worried about that person.
Right.
And so your take home is do your screenings, right? Patients are most likely to find a mass sooner than a physician. So the monthly self-breast exams, even though they were downplayed by that governmental study, they're super, super important.
Okay.
And then also be an advocate, right? You know, do that. Get your studies, whatever it is, your mammogram, your colonoscopy, everybody. You have to be an active participant. But don't assume just because, you know, everybody thinks it's genetically driven. I'm like, it's not. You know, I'm not worried about someone who raises their hand and their mom had breast cancer because that person is so on it. I'm worried about the other 60 to 80% are like, I have no family history. I'm not worried. That's the person that worries me.
That's the person.
So
and that's why we start screening at 40.
Yep.
Every year moving forward, family history or not,
That's
let's
exactly
get out there and get those screenings done.
Absolutely.
And then if anything does turn up, we've got teams like yours that are going to continue to take care of them.
We do. We have three of us here. We're all really good research. We're all experienced. Yeah. And you've got a great other team, medical oncologists, radiation oncologists, staff. It's a whole good team.
Beautiful.
Absolutely.
Glad to hear it. Thank you very much for joining us.
Of
Really
course.
appreciate that.
Of course.
And thank you all for joining us as well this afternoon.
Thank
Have
you.
a great day.